brief cope scale. The results are showing significant results in factorial correlation, interfactor correlation, and you can see positive and supportive coping with significant figures. This is the mean and standard deviation, and you can see supportive coping, that is the gain from their support group, and the stress, you can see the stress in working and non-working women is equally significant. And with the age group, we try to compare the age groups that we can see that with the age, stress is decreased and coping is increased. The implication of the studies are always there. This study will explore ways for the better understanding of psychologists to help single women dealing with their perceived stress, and single women who are at home can get knowledge and insight for the improvement of their coping skills through this study. Awareness programs can be developed for general population concerning marital status and expectation for a marriage.
Thank you very much. For our next speaker, I would like to invite Dr. Howard Chaudhary. He is an associate professor at Continental Medical College, and he is going to present his paper on sexual functioning and quality of life in female asthmatics.
First of all, I would like to thank all the organizers for organizing this first conference on social psychology. I take it as a big breakthrough because this is a sector that has been tremendously ignored, and I would like to congratulate Professor Yazbati for all his efforts which he put into all this. My topic is sexual functioning among the female asthmatics. Few disclaimers: I'm not a psychiatrist. I have nothing to do with psychiatry and psychology, but still, it came into my domain. I'll talk about it later on.
Something to do with psychology.
Yes, my wife is a psychologist. So when you looked at asthma, basically asthma is a variable. It's a disease containing a variable and recurring symptoms that cause a reversible airflow obstruction, and most of the time patient presents to you with bronchospasm and bronchoconstriction. The issue is the population, which is around 50% of our population, the females. Although the allergens which cause this flare-up is common among both males and females, but there is one aspect of the disease which always has been ignored till now. We know that asthma is a multi-system disease that affects every organ of the body, but it also affects the physical and mental well-being of the patient. And it has a great impact on the quality of life as well as the sexual functioning of the patients as such. But the thing is, in our culture, talking about sexuality is a taboo for males. And when you come to talk about the females, don't even consider talking about it. When I moved to Pakistan a couple of years back, I tried to take a detailed medical history from a female asthmatic. And I asked her a few questions regarding sexuality, and it was like, she complained that this doctor is asking me indecent questions. So, doing a research on such a topic, which is considered as a taboo, was not an easy task. Our main aim was to assess the quality of life and female sexual functioning in asthmatic patients, and we were going to compare them with the normal patients as well. So we took 200 patients who presented to Continental Medical College, to the Rehabilitation Trust Hospital. They were all in the childbearing ages, 18 to 35 years of age. 50 of them were excluded depending on the criteria, which we're just going to talk about. So we were left with 75 patients which were in the study arm, and we took also 75 age-matched patients as a control group. Our inclusion criteria were that they should have a normal menstrual cycle, they should be sexually active, and they should have a diagnosis of bronchial asthma based on the standard protocols. We excluded all those who had some sort of chronic illnesses, any medical history of depression, and there was also the use of drugs such as antidepressants. And we also excluded all the patients who were known to have some sort of gynecological issue, because that would definitely impact their sexual functioning. We used a tool which is known as FSFI, Female Sexual Functioning Index. It's a self-evaluating and multi-dimensional tool that gives a holistic overview for all the spheres of female sexual functioning. Basically, this tool consists of 19 items which are divided into 6 collective domains. The domains that are covered are sexual desires, sexual arousal, orgasms, sexual satisfaction, pain, and lubrication during the sexual intercourse. Just by looking at these domains, you can well imagine what sort of difficulties we would have had. I had to train 2 of my house officers to take the history, and both of them ran away after 1 week because their parents did not think it was very appropriate for them to take history such as this. So, clinical significant female sexual dysfunctions are diagnosed at a values which are lower than or equal to 16 points of FSFI. Just looking at the few parameters, I'm not a very scientific person, let me tell you. I'm a very simple person. One thing which I hate is the numbers. So, right here, most of our patients were female. There was not much of a difference between the BMI and the waist-hip ratio, and other parameters of both the groups were nearly the same. When we talked about the social demographics of the group, the patients, the group which was in the patient group, they had a lower incidence of regular physical exercises. They had a poor exposure to sunlight, and they had a high level of perceived stress. Coming to the dietary habits, that was the group that took very minimum amount of milk and rice. I think it's our basic misconceptions about the food which are carried out in our cultural practices. When we looked at the retrograde analysis, we found that the housewives were the group who had the highest incidence of perceived stress. I don't know why, but this was the finding. Most of our asthmatics were young, and they did fall into a group which is known as a moderately well-controlled group. Very few of them were outside this moderately well-controlled. Poorly controlled were very minimal. Coming to our index, which is FSFI, there was a significant difference between the sexual arousal of these patients. There was a significant difference between the sexual satisfaction which they achieved. Lubrication was low in patients who belonged to this group, and most of them did not gain their orgasm. Strange enough, sexual desire did not differ between both the groups. It would be a good idea to do some further large-scale studies to see why sexual desire was not that much affected, whereas they had the effect on their arousal, they had effect on their lubrication, they had effect on their orgasm, and they also had a lower sexual satisfaction. These are the few references which we took, and I would like to conclude just by showing one slide. The way that we treat diseases should be changed. We should have a very holistic approach. All physicians should pair up with psychiatrists, they should pair up with a patient rehabilitation consultant, and they should pair up with psychologists. My understanding is, I may be wrong, you are experts on this sphere. Around 80% of the Pakistani population, they do have some sort of psychiatric illnesses. So if you treat a patient without doing a teamwork, then I don't think you are going to get the required result.
Thank you, Dr. Now our next speaker is Dr. Nazish Imran. She is an associate and head of Department of Child Psychiatry at King Edward Medical University, Lahore. And she is going to present a paper on the illness perception in patients of schizophrenia, a preliminary investigation from Lahore, Pakistan.
Thank you, Aisha, and thank you, organizers, for giving me opportunity to talk about another sort of brief study which we did. Yesterday we talked about the teacher's perception regarding the school mental health. So this is a study done in collaboration with colleagues in the adult psychiatry regarding illness perceptions in the patients of schizophrenia. But when we talk about illness perceptions, it's generally a way a patient understands their illness and its impact on their day-to-day life. And the studies have shown that illness perceptions are associated with significant emotional distress, disability. It has an impact on the adherence to the recommended treatment and recovery, and it influences treatment outcome as well. And in order to improve the treatment outcome in patients with schizophrenia, just writing the medication is not enough. We need to know how do they themselves perceive their illness, as well as how the caregivers perceive the illness and how we can help them. So the objective of the study was to explore the patient's beliefs about their illness, their perceived social support, and its impact on their attitudes towards the pharmacological treatment in Lahore. As part of the study, the similar study was done with the relatives as well, and we are in the process of analyzing the data at the moment. We got the ethical approval from the IRB of KEMU. We used 4 research measures which were translated into Urdu by using the standard protocol of translation and then getting pilot study. Socio-demographic questions. We used the illness perception questionnaire for schizophrenia, drug attitude inventory, the short version which has 10 items, and we used the multidimensional scale of perceived social support. Illness perception questionnaire is a 5-point Likert scale which ranges from strongly disagree to strongly agree, and there are various subscales covering the causes, what are the patient's perceptions regarding the timeline, whether they think it's a chronic or a cyclical illnesses, what are the consequences, illness coherence, do they think they have any personal control or does the treatment help them in the illness process, and what are the emotional representation. Drug attitude inventory is a 10-item true-false questions. The more positive score shows a positive attitude towards taking medication, whereas the negative score shows a negative attitude. And the perceived social support scale is a 12-item scale which assesses the perceived social support from the family and friends. And it has got high, moderate, and low scores. Inclusion criteria were informed consent from the patient aged above 18 up to 65 years. Patients who are meeting DSM-5 criteria for schizophrenia, and they were supposed to have at least a stable mental state for at least 4 weeks prior to the data being collected. Patients with a primary diagnosis of learning disability, any other mental and physical illness, and substance abuse were excluded from the study. All the measures were completed by 100 individuals from 2 public sector hospitals in Lahore. There were 55 females and 45 male patients. Average illness duration in all these patients were around 6 years. And average length of contact with the mental health services, whether as an outpatient or an inpatient, for almost 5 years. When we looked at the causes of mental illness, majority of the causes which were endorsed by the patients were stress, they felt family problems, lack of friends, and financial worries were responsible for them becoming mentally ill. They didn't felt that drugs or alcohol or any other illicit drugs had any role to do regarding their illness. When we looked at the illness perceptions, there were significant negative consequences which patients perceived. They had negative emotional response of anger, anxiety, and fear as part of diagnosis of their illness. And they had very poor understanding of their mental illness as well as the role the drugs or psychological treatment could have played in their treatment. Male patients, when we compared, had better understanding, statistically significant scores were observed. regarding the treatment control, as well as male patients had a comparatively better understanding of their illness compared to the female patients suffering from schizophrenia. When we did the multiple regression coefficient, the patients who believed that the treatment can help did have sort of better, was an independent predictor of, or had a positive influence on their drug taking attitude, as well as the patients who showed a better understanding of their illness. They were more likely to continue with their treatment and had a positive attitude towards taking medications. The patients who sort of had more negative consequences on the illness perception scale, they sort of felt that they were not having enough support from the family, from their friends or the loved ones as well. So it has it was an independent negative predictor of perceived social support in our sample. The limitations of this study were that the sample size was small and we sort of just focused on 2 public sector hospitals, but a large scale study would be able to, if we are able to replicate these results or at multiple sites across the country, whether the illness perceptions are the same or they vary according to the different culture in different parts of our part of the world. Then the tools, although they showed good internal reliability of around 0.8, 0.9, but these tools have not been validated in our part of the world. So that is one of the limitations of the study. And it was a cross-sectional study design. You can get some idea, but whenever you are looking at perception, it's always better to have triangulation of data by using the qualitative approach, because the exact sentences and the terms which the patients and the caregivers come up in qualitative study give actually a much more robust sort of data regarding how the patients perceive and what are the impact of these things on their day-to-day life. So in conclusion, patients' perceptions about their own illness is a predictor of their drug-taking attitude as well as perceived social support. Therefore, as clinicians, just writing the medication is not enough. All these patients had contact with the mental health services for at least almost more than 4 years. But it appears that they were not psychoeducated enough, they were not given enough information. So despite sort of them having a stable mental state for some time, they didn't have a better understanding of their illness, neither its impact and neither the role of the medication as well as other psychological work on their illness. And therefore it highlights the importance of psychoeducation. We do have to develop new interventions focusing on the how we can psychoeducate our patients' population and their caregivers in a better way. And it does highlight the focusing on the holistic approach to the practice of psychiatry, which is the need of the day. So thank you very much.
Thank you, Dr. Nazish. Now our next speaker is Mr. Sajid Iqbal. He is a clinical psychologist at Institute of Psychology, Karachi University. He is going to present his paper on the role of maternal involvement in adolescents' academic achievement.
Assalamu alaikum. My name is Sajid Iqbal and I is presenting the role of maternal involvement in adolescents' academic achievement. Basically पहले जो मिस गिवन ने रिसर्च प्रेजेंट की थी उसी का एक पार्ट या कह लें हम के 2 पार्ट में हमने डिवाइड किया हुआ है इसको. पहले हमने मैटरनल जो एटॉमी सपोर्ट था उसका रिलेशनशिप देखा कि एडोलेसेंट्स की वेल बीइंग के साथ उसका क्या है, और उसके बाद जो मैटरनल इन्वॉल्वमेंट एकेडमिक अचीवमेंट के साथ. The purpose of the current study was to investigate the unique role of perceived maternal involvement in academic achievement among adolescent students in Karachi, Pakistan. Adolescence is the most sensitive period in human development process, and adolescents are continuously changing mentally, physically, and psychologically. It is a process of learning and exploring one's own world and independence. Education is considered as one of the important things in one's life, and it is expected to every student to do their best. Parents are extensively regarded as the most prominent figure in the development of process of children and adolescents. Parental influence is not simply an involvement and action, but often a combination of action and inaction. Parent involvement in a child's education is consistently found to be associated with the child's academic performance. Specifically, children whose parents are more involved in their education have higher level of academic performance than children whose parents are involved to a lesser degree. Parent involvement is therefore an important construct to examine given the importance of a child's early academic success. Parental involvement may be different from culture to culture and society to society and may have different types which might have different influence on academic performance of children. Parental involvement may include activities like helping children and reading, encouraging them to do their homework independently, monitoring their activities inside the house and outside the four walls of their house, and providing coaching services for improving their learning in different subjects. Numerous studies have been done to confirm the assumption that students do better when their parents are involved in their education. According to a review of 66 studies of how students succeed in school when parents become involved in children's education at school and in the community, the results include one or more of the following: higher grades and test scores, better attendance, and regularly completed assignments. Brad, Christian, Morrison, and Pint have reported that the child-parent interaction are perhaps the most influential on the child's social, emotional, and academic development. Further, a child's early acquisition of academic skills is promoted by stimulating and responsive parenting practices. Thus, it has been suggested that specific parenting variables that are amenable to change and have an important impact on the child's academic performance be examined to increase a child's academic performance. This has led to a renewed focus on the relation between parenting practices at home and the relation of these practices to outcome in the school environment. A hypothesis: perceived maternal involvement will be a significant predictor of academic achievement in adolescents. The sample of this research consists of 508 adolescents, 243 males, 265 males and 243 females, and their age ranging from 12 to 19 years. Total sample 508 adolescents जो हमने लिया इसमें से 52% मेल थे and 47.8 was girls, और participations age range between 5 to 19 years. 12 to 19 years. Adolescents were taken from different government and private schools, colleges, universities in Karachi through simple random technique. The perception of parent scale, the college student scale was used to measure the perception of internal involvement. It is a 42 item inventory, 21 for mothers and 21 for fathers, developed for late adolescents and older individuals. और ये स्केल जो है ये पाकिस्तानी कल्चर में ट्रांसलेटेड और वैलिडेटेड किया हुआ है और एकेडमिक अचीवमेंट obtained through grade point average of the adolescents in last year. Linear regression analysis was applied to explore the predictive relationship of perceived maternal involvement and academic achievement among adolescents. All statistical computation were done through statistical package for social sciences, SPSS 70. Significant regression equation was found. Descriptive statistics of age according to gender. और ये model summary of linear regression analysis, coefficient statistics table. Conclusion: these findings have implication for clinicians, parents, and teachers who contribute in the better mental health of adolescents and achievement in school. Every student wants to do best in studies and set higher expectations from self, and at the same time parents and teachers also expect higher achievement from their children students. It was concluded from the present study that there was a significant relationship between the two variables, academic activities and the level of academic achievement of children. These are some references.
Thank you, Sajid, for your valuable talk. Now I would like to invite Professor Aisha Haas. She is head department of child psychiatry at Institute of Psychiatry, Rawalpindi Medical University, and she is going to present her paper on childhood trauma revisited. And please.
Just a clarification, I'm not professor yet. I'm not head of IUP. I'm head of the Child and Adolescent Unit. But thank you for the promotion. So I'm going to talk about trauma in children and adolescents. Next page. Can you tell me where to change? Give us a change. So I'm going to quickly talk about some facts and figures, and then I'm going to talk about the role of trauma in causality of mental illness, and then briefly touch upon child sex abuse. So I'll start with this myth, age-old myth in our culture that mental health problems do not affect children or youth, and any problems they have are just part of growing up. However, the figures from National Institute of Mental Health tell us otherwise. So actually, mental health conditions in children are a huge concern because 1 in 5 children lives with a mental health condition. And as you can see, anxiety disorders top the list, followed by behavior disorders, then internalizing problems like mood disorders, followed by substance use disorders. And another interesting fact is that unlike physical illness, mental illness begins very early in life. So actually, all the adult patients that you and I see, about 75% of them, they started with mental health issues by the age of 15. And so we see that young people with mental disorders are having mental health issues in the prime of their life, which is obviously very sad. And another issue is that there's a huge mental health gap. So the provision of treatment does not match the intensity and the incidence of mental health issues in children. And so prevention is very important. And I'm going to be talking a bit more about how we need to focus on prevention. And when we talk of causality, we know that it's an interplay between genes and exposure to adversity. So we can't blame genes all the time. And unfortunately, adversity many times begins at home. And family, as we all know, is the most important first microenvironment for children. And if adversity is beginning there, obviously it's inescapable for the child and very, very traumatic and very unfortunate. So when we talk of trauma, the WHO figures are that 1 in 4 children will experience a significant traumatic event before reaching adulthood. And they describe trauma into these 5 kinds. So there can be physical abuse, which is pretty rampant in our society. Emotional abuse is more insidious, not visible like physical abuse, but very much there and happens along with physical abuse many times. Sexual abuse is another long story, very much common in, I shouldn't say very much common, but I mean it's there and it's not talked about and lies really hidden, and there's this huge conspiracy of silence around it. Then there's neglect and commercial exploitation of children. I think you heard about this study yesterday also. So if we talk about trauma and don't talk about the adverse childhood experiences study, I think that won't be fair. So this is a beautiful piece of work that was done in the 1990s in USA. And according to them, you will see that the incidence is much higher than given by WHO. So only about 36% of the children escape trauma. So about 64% of the children would suffer from either 1, 2, 3, or 4 traumatic events, which is a very huge incidence, I would say. And in this study, they followed people who had childhood trauma, and I was absolutely shocked when I read this study, because I expected depression to be there and suicidality to be there. But how about obesity? And actually, this study was carried out in an obesity clinic in Los Angeles. And there's higher incidence of diabetes and heart disease and cancer and stroke and COPD and broken bones. Oh my God. So you name it, and trauma predisposes you to all these health concerns. Health behaviors become pretty risky. And all in all, the life potential of that child does not reach its optimum level. This is just a slide to show you that they found out at least 40 health issues that are connected with trauma. And look at this beautiful pyramid. It's beautiful, no doubt, but very, very sad. So a child suffering from an adverse childhood experience will have disrupted neurodevelopment. So trauma actually alters your brain structure and function. And how does this happen? We all read in medical school how stress activates our hypothalamic, hypophyseal, adrenal axis.
Yeah,
So that's very well. We learned that if we are in a jungle and a bear comes and outpours adrenaline and to produce the fight, flight, and fright reaction, which is very adaptive in that situation. But what if you are not in a jungle? And what if there is no bear? And what if the bear is coming to your home every night? So the child is confronted with this trauma day in and day out and outpours adrenaline again and again and again. And that adrenaline is actually very disruptive for the developing brain. And that's how it causes disruption in the neurodevelopment. And we know now from many studies that social development, emotional and cognitive development is impaired. Their health risk behaviors are impaired, ultimately leading to disease. And unfortunately, look at the tip of the pyramid, this early death. So as we learned yesterday, children who suffer from 4 traumas or more will actually die 20 years before their expected lifespan, which is so, so sad, because for no fault of theirs, they were subjected to trauma, and it may lead to early death. And another very interesting study that I would like to quote here is by this developmental psychologist by the name of Ter. She has termed trauma as the rheumatic fever of child psychiatry. Like rheumatic fever, we all know, is an infection by beta hemolytic streptococcus and giving you a sore throat. So trauma also originates from the outside. It's never generated solely within the child's mind. Again, like rheumatic fever lies dormant in your body, and years later, it may cause rheumatic heart disease. And so trauma doesn't only have short-term effects. It stays within the recesses of the brain of the child, causing damage and lifelong difficulties, and may cause disability and difficulties much later in life. So, ladies and gentlemen, I think childhood experiences are very, very powerful determinants of whom we become as adults, and this picture is very explanatory. So I'll just recap for you the things that I've highlighted. Trauma is common in children and adolescents. It impacts the brain and nervous system. It causes serious and chronic health, behavioral health, and social problems. And it's often unrecognized, ignored, or denied. The one good thing about trauma, if you ask me, is that it's preventable. And in that sense, I think it's a very, very, very important public health issue. If we want a progressive nation, I think we need to protect our children. And talking of children, we need to protect them from trauma. So I think promotion of healthy psychosocial experiences, giving them a good home, forming healthy attachments, and nurturing and nourishing them in our home is going to be a very cost-effective target. We're going to save a lot of money because we are going to save a lot of mental ill health in our individuals. I'll skip these 2 slides and come to this very personal venture of ours, very dear to my heart. I'm really passionate about this. So because of this thought, you know, when we've been doing child psychiatry in the Institute for over 10 years now, and day in and day out, I was seeing children with behavioral issues and with internalizing difficulties, and I would often find something wrong in the family, something problematic with the parenting, misguided and bad parenting, and trauma in the children. So I think we need to move beyond our outdoor clinics. We need to move into the community and raise the idea of prevention. And that's how our campaign by the name of Ankahi was born. And it was born under the umbrella of a parenting program which we are working on to give our parents a culturally appropriate parenting manual and parenting methods to nourish our children. And under that, we have this chapter on child sex abuse because we want to raise awareness against trauma in general and sex abuse in particular. What we've been able to do in this campaign, we started off with this little video, and I would like to share with you a small teaser of it. I'm not sure if it will run. Video.
हमें अपने बच्चों की जिस्मानी सेहत के साथ साथ नफ्सियाती सेहत की नशोनुमा करनी होगी।
So this is a teaser of a 15 to 16 minute small video, because when we were doing this campaign and we thought about raising awareness, we thought that video is much more powerful than the written word, and so we've developed this 15-minute small clip which I would want that it should reach every home and every parent in Pakistan. Whether it's the deserts of Sindh or the mountains of the north. And I would really invite, like-minded people at this forum, if they could help us spread the name and spread this message, so that our ultimate aim is that, like we are vaccinating our children against polio, so we should vaccinate all children of Pakistan against trauma, and all parents to be made aware of how important it is, because we don't know that, and our eyes do not see what the mind doesn't know. So in my opinion, the first step to raise healthy children is to give them a better home and to give them an environment which is free of trauma. Under this campaign, after the awareness video, we are doing seminars and workshops with different medical schools and universities. We've tried to approach schools, and we are trying to join hands with our colleagues working in psychiatry in different provinces. We hope to translate this video into regional languages. We are working on another video on prevention and perhaps then some tips on management, and try and spread the word around. Thank you very much, ladies and gentlemen.
Thank you, Dr. Aisha, for this valuable talk. Now I will like to invite my next presenter for this session, Professor Jameel Hussain. He is Professor of Psychiatry at Indus Medical College, Hyderabad, and he is going to give his talk today on birth order and psychiatric comorbidities.
Bismillahirrahmanirrahim. Professor Riyad Bhatti, Professor Madam Malik, Yusuf Zaisa, Nasa, the audience of this symposium are now over-medicated by me, because in the first day I am on the dais. Very first day I simply offered a vision that how psychiatry can go into at the grassroots levels. And yesterday I went for the post-retirement syndrome. Just after retirement, how do you go? And this paper, written 4 years back and first time read at Madam Malik's conference, and very recently at European Psychiatric Conference in Italy. And then there I realized that such papers are not suitable for the European Society. Reason being, there is no order. They either don't produce, or if at all they are going to produce just one or two. So this paper had significance in our rural population, keeping in view the areas that how different psychiatric diagnosis they run through that particular disorder. Next. Next. So this is Pakistan, and this Pakistan is such a beloved country that you go all over the world, and once you reach at Karachi airport, then you really feel that you are really at home. So this country needs not only your love and support, but also the taking of psychiatric services to the periphery of other than Islamabad and Karachi, Lahore, Peshawar. Next. Next. Pakistan is an important country in South Asia with unique socio-cultural diversity and spatial geopolitical situation, situated at the crossroad of South Asia, which is geographically very important, not only important for South Asia, but even if you move to America, and then it is significant, and as a result of which Malala is back after 5 years. It captures population of 150 million. Some people would believe that it is more than 200 million. Next. Birth order in any community is very important by keeping in view the social perspective, and this forum is social psychiatry. Most of the culture of the world, male gender has got more importance as compared to the female, and in psychiatry this issue has been discussed in relation with so many psychiatric illnesses. Next. I don't know this particular slide would attract any person or not, but this is the actual order of our 68% population of Pakistan. Next. The lower and the middle social class understand more children means more helping hands. जितने बच्चे ज़्यादा इतने ही ज़्यादा काम करने वाले लोग. And more are available to meet with the agro-based requirement. That means the 60% of population really understand that more helping hand needed by the rural population. Next. First time this issue was discussed by Alfred Adler, proposed the effect of birth order on human personality characteristics. Next. The debate on the birth order characteristics later on involved psychiatric illnesses such as obsessive compulsive disorder, schizophrenia, gender identity, and other disorders. Next. The study pointed out interaction between the birth order and parental age. In European society, years, in Germany especially, at the age of 40 the person is young. But here, just you cross 21 years age and the parents are worried about marriage, where the people don't understand whether they need really a marriage or not. Next. In Pakistani scenario, importance of this paper describes the preliminary perspective. ये पहली ऐसी स्टडी है पाकिस्तान के अंदर जिस पर ये लोगों ने बात की. Next. Cross-sectional study 100 consecutive subjects attending psychiatric outpatient at Labrador University Psychiatric Department, 2012. The consecutive cases were suffering from different diagnostic profiles and have been assessed with a number of siblings and diagnostic breakdown. Next. From 9 years to 30 years, the first group, age group, male, female, gender, the male 32 and the female 25. The total number was 57 and 43 years of gender difference. Next. First child, second child, third child, up to this level, the parents try to get the first child male, and if at all you produce this daughter, then some people, intellectuals, they would say simply yes, okay. But our rural population especially and the partial urban population would definitely go that first child should be the male. However, in this study, the birth order, male patients, female patients, however, these were wanted. But afterward, once you go down from third to fourth, then parents' wish is not there, but it is the wish of God. He wanted to give, the Punjabi mein kehte hain Allah janda hai lai jao. Next. Anxiety disorder, 38% was detected in this particular study. Next. Rural areas में जो birth order पे एक important चीज आई थी वो थी cousin marriages. Cousin marriage means mental retardation especially, and the other illnesses, they completely move in that particular family scenario. And we simply use the word कि बाबा नानी मटायो या दादी मटायो, यानी नानी चेंज करो या दादी चेंज करो, और ये चेंज करना उनके बस में नहीं होता है, क्योंकि ये उनको कजन मैरिज करनी होती है, फूफीजाद, मामूजाद, तायाजाद, उससे बाहर नहीं निकलते. एज a result of which these particular areas they completely present, absolutely present in that. Anxiety and related disorder, 38% cases are more in number, followed by depression in 22% and mental retardation 11%. So 11% in mental retardation is really the way Madam asked, that the child trauma, whether that was a physical trauma or emotional trauma, but if the number, क्योंकि मोहब्बत भी आपके पास 1 किलो होगी या 5 किलो होगी, और शुरू वाले 2-3 बच्चे वो खा जाते हैं, और बाद में जो पैदा होने वाले वो प्रोफेसर कोट करना चाहूँगा मैं उनसे इजाज़त के साथ, प्रोफेसर मुबशर मलिक ने जब ये मेरा पेपर सुना तो बड़े तारीफ की, कहने लगे कम तो तू चंगा किया पर तेरे अपने बच्चे कितने ने. तो मैंने अर्ज किया, मैंने कहा सर 3 बीवियों से 4 बच्चे. तो कहने लगे यार 3 बीवियों से 4 बच्चे, मेरे तो 1 से 7 हैं. मैंने कहा उस वक्त तक पंजाब यूनिवर्सिटी ने ये ऑर्डिनेंस बनाया नहीं था कि वुमन ट्रामा जो होता है वो ये भी है. बोले यार ये तो चंगा ही होया, उस ऑर्डिनेंस तो पहले मैं कम कर देता. नेक्स्ट, sex different in 100 cases with male, yes, research has mentioned that female population are frequent with psychiatric problems. तो 2030 में जब ये पॉपुलेशन मेडिकल कॉलेजेस की जो आप हालत देख रहे हैं कि ओवर 65% ज़्यादा यूनिवर्सिटी में लड़कियां हैं, और डॉ मेडिकल कॉलेज और सिंध मेडिकल कॉलेज में ये रेशो 85% है. तो 2030 के अंदर रेशो वही होगा जैसे मैंने कल इन सबको इजाज़त दी है कि जो लोग 60 के हो रहे हैं उनको शरई तौर पर एक और जाना चाहिए, मगर 2030 के बाद आप शरीयत हो या ना हो करना पड़ेगा. नेक्स्ट. Dominant patients are young age group and male subjects are more frequent, while the second group, third group, we have already discussed. Next. A change in social setup during 2-3 decades by keeping in view the national and international socio-political situation in Pakistan around that the younger age. However, this study focus only on 100 patients. Next. First child usually expected within 1 year. Psychiatrists हज़रात कहते हैं अगर मियाँ बीवी एक साथ हैं और फिर प्रोड्यूस ना करें तो पहले मेल को देखें और मेल ही को पहले देखना चाहिए. मगर पाकिस्तान के अंदर फिर कल्चरल जो टैबूज और दूसरी चीज़ें हैं उसके अंदर ये चलता है. नेक्स्ट. सेकेंड बर्थ ऑर्डर यूजुअली एक्सपेक्टेड. नेक्स्ट. कल जो मैंने इम्पोर्टेंट बात की थी कि जो बड़े बच्चे ज़्यादातर मुल्क छोड़ के जो गए हैं उसका सबसे बड़ा कम्युनिटी जो इम्पैक्ट आया वो ये कि पूरे नेशन से जैसे सियासी तौर पर पाकिस्तानी लोग कैप्सुलेटेड हो गए कि अब सियासतदानों से ये एक्सपेक्ट कुछ नहीं करते. इसी तरह ये हमारी जो जनरेशन अब रिटायरमेंट पे जो पहुंच रही है वो भी अपने बच्चों से एक्सपेक्ट नहीं करते और बिल्कुल हम उसी अंदाज में सोचने लगे जैसे जर्मनी के लोग या स्कैंडिनेवियन कंट्रीज के लोग भी सोचने लगे कि जब इन्होंने 18 साल के बाद अपने ही रास्ते पे जाना है तो फिर इन्हें प्रोड्यूस करने की जरूरत है. नेक्स्ट. I never saw my parents young. यूरोप ये है एक सिलसिला कि 7वें 8वें नंबर पर 6ठे नंबर पर जो बच्चे पैदा होते हैं तो उस वक्त तक हम लोग 40 साल के हैं और 40 साल की उम्र के बच्चों को वालिदैन जो है वो ऐसे उछाल नहीं सकते. हम लोग तो बहुत पहले नहीं उछाल पा रहे थे, मगर ये ख्वाहिश कहीं न कहीं डायनामिक्स में जाती है और वो ख्वाहिश बहुत तंग करते आगे चलते. जैसे रिटायर्ड प्रोफेसरों के जो कॉलेजेस हैं उसमें जो फर्स्ट ईयर सेकेंड ईयर में स्टूडेंट जाते हैं उन्होंने कभी प्रोफेसर को यंग तो देखा ही नहीं होता उनका ख्याल है कि ये सारे इस तरह से आते हैं जैसे हम लोग आजकल आ रहे हैं, तो उससे बड़ा डिफरेंस ये आ रहा है पाकिस्तानी कम्युनिटी में कि जी प्रोफेसर क्या होता है कि वो बिल्कुल मोर और लेस स्टिक्स और विदाउट स्टिक जो आ रहे हैं, तो ये लोग शिकायत करते हैं 6, 7, 8 नंबर पे। उसके आमतौर पे जब 7वां 8वां बच्चा यंग होता है तो वालिदैन नहीं होते। नेक्स्ट, usually the older our children see their parents in 40s and 50s, therefore the younger children have the peer group of siblings children. Peer victimization in childhood is associated with psychotic symptoms। जो सेक्सुअल ट्रामा की मैडम आपने बात की थी अपने पेपर्स के अंदर, वो रूरल पॉपुलेशन में और मदरसों में और थोड़ा सा 1-2 इदारे और हैं, वहाँ पर ये केस फ्रीक्वेंट आजकल हैं सिंध के अंदर। आप हम कॉमन तो नहीं कह सकते बट इट इज वेरी मच फ्रीक्वेंट। नेक्स्ट, द नंबर ऑफ चिल्ड्रेन, ब्राउन हैरिस ने 1978 में कैम्बरवेल पता नहीं कहाँ स्टडी की थी, तो उसमें उन्होंने 3 बच्चों की बात की थी कि 14 साल से कम हो। हमारे यहाँ ये नंबर काउंट में नहीं होता है, इसलिए हाँ जी ठीक है। जो दादी बनने जा रही है वो कहती नहीं, ये जो पोता मेरा है इसके हाथ मैं मेहंदी लगे देखना चाहती हूँ, उसके बाद भावे मर जाऊं, समझिए, मगर ए हो जाए। खुद मेरा अपना किस्सा ये था कि मैंने सामान ला के देता कि अपनी बेटी का आप जहेज बना लें, मगर उस बेटी की शादी करने के बाद उसने उसकी बेटी का भी जहेज बनाया मेरी वालदा कि नहीं बस इसका भी मैं नहीं करना है। तो एक कल्चरल हमारे हिसाब से बहुत है, मगर ये चीज़ समझनी चाहिए कि उस जनरेशन को मोहब्बत के अगर ये रंग अच्छे लगते थे तो उनको ये चीज़ देनी चाहिए। नेक्स्ट, यंग पेशेंट are more 57% and this group males now number, while in the second group the age range, ठीक है बात करनी इसका आगे चलें। The birth order of the patient in the major assessment। नेक्स्ट, अब थोड़ा सा इसमें विजन आप ये डाल दें कि क्या चाइना में साइकियाट्रिस्ट हजरात ने कितने पेपर्स पढ़े कि पूरी दुनिया में मेल सुसाइड ज्यादा कर रहे हैं, और लेकिन चाइना में आप जाते हैं तो चाइना में इट इज मोर और लेस द फीमेल्स डोमिनेट्स, और उसके लिए कहा जाता है कि द गवर्नमेंट चैलेंज देयर रिप्रोडक्शन कि दे आर नॉट कैपेबल टू प्रोड्यूस मोर देन 1 चाइल्ड एंड इफ इज मेल और फीमेल, तो हर चाइनीज औरत वाज नॉट प्रोन टू गो फॉर द अबॉर्शन। सो आफ्टर 10-15 years कंटिन्यूस स्ट्रगल नाउ दे आर अलाउड कि नहीं 2 बच्चे होने चाहिए। एक अगर पहले बेटा हो जाता है तो आप बच्चे पैदा नहीं कर सकते, लेकिन अगर पहली बेटी पैदा होती है तो आप एक और पैदा कर सकते हो, फिर वो बेशक बेटी हो। ऑस्ट्रेलिया में भी यही हालत जारी है कि जो जिनकी एज बढ़ गई है तो उसमें लेकिन बच्चों की एज 65% जो पॉपुलेशन है 65 की, तो वो 65 अबव है स्कैंडिनेवियन कंट्री में, तो बच्चे नजर नहीं आते। और हम कहते हैं कि हमारे आंगन में फूल कब खिलेगा और कितने खिलेंगे। नेक्स्ट, in Australia the reproduction rate is less than the mortality। Children issues can be discussed। नेक्स्ट चैलेंज, उसकी वजह कहते हैं कि जो ऑस्ट्रेलियन लड़कियां जिनसे एक आध से मैंने भी रोमांस किया, तो उन्होंने कहा कि जी आप बिल्कुल रोमांस करें, मगर 35 साल की मेरी एज हो गई है और अभी मेरा शादी का इरादा नहीं है। तो मैंने कहा मैं शादी तो नहीं करना चाहता। उन्होंने कहा ठीक है फिर आप ऑस्ट्रेलिया 3 हफ्ते के लिए आए, 3 दिन में हम लोग दोस्ती नहीं कर सकते। नेक्स्ट, बांग्लादेश का रोमांस भी करें और साइकिल रिक्शा भी ले लें, मगर ये एक उनका जिंदगी का एक आबादी कंट्रोल किए बगैर हम लोग कुछ नहीं कर सकते। साइकियाट्रिस्ट कितने हैं? 450। आबादी कितनी थी? 18। अब वो आबादी हो गई है 22 को, और साइकियाट्रिस्ट की तादाद वही 450, 450, 500 के अंदर चलेगा। लेकिन हमने इतना जरूर किया है कि जो हैदराबाद से DPM और MD वगैरह निकले तो उन्होंने सिंध के 19 जिलों के अंदर अपनी मौजूदगी को साबित किया है। प्रोफेसर एजाज हैदर ने 70 DPM पैदा किए थे, मेरे पास 45 निकले, और उन वजह से क्या हुआ कि आज भी हमें कहीं न कहीं कम से कम एक डिस्ट्रिक्ट में एक साइकियाट्रिस्ट तो इस इश्यू पे बात कर सकता है। नेक्स्ट, मैक्सिमम जो अब आपको रेयरली म्यूजियम आर्काइव्स वगैरह में मिलेंगे, क्योंकि अब ये लोग, मैंने अमेरिका में हार्डली एक आध फैमिली देखी थी, और वो भी एक अंग्रेजी के अलावा जबान बोल रहे थे। मैंने कहा आप क्या बोल रहे हैं? उन्होंने कहा हम लोग स्पेनिश बोल रहे हैं। मैंने कहा अमेरिकन तो नहीं कहते। नहीं, मुझे नहीं पता कि इस उम्र में पोते होने चाहिए, नवासे होने चाहिए या अपने बच्चे होने चाहिए। इस पे फिर डॉक्टर बशीर से बात करेंगे। नेक्स्ट, जो ड्रामा है वो असल में बच्चों का ये है, ये वो ड्रामा है। नेक्स्ट, ये रोती हंसती मुस्कुराती शक्ल जिसपे हमेशा घर के अंदर किलकारी एक होती है करके जो बच्चे करते हैं, उसके लिए अब ये मौजूदा नस्ल तरस रही है, क्योंकि वो नहीं है। माँ परेशान होती है, मोबाइल देती है उसके हाथ में, और वो उसने पूरा हाथ यूं करके उसको आगे, जो मुझे अभी तक चलाना नहीं आता। नेक्स्ट, मुझे नहीं पता कि निसार साहब इन आंखों में आंसू देखकर कितना खुश हैं। नेक्स्ट, ये सारे लोग हैं इंटरनेशनल सिनेरियो के, और सब लोग कुछ ना कुछ अपना हिस्सा उन्होंने साइकियाट्री में डाला है अपने अपने लोग। नेक्स्ट, थैंक यू वेरी मच।
Thank you, Professor Janitza, for your valuable talk. And most of the audience are amused by your talk. And that's a very good sign. And now I would like to invite Professor Azizur Rahman. He is Principal and Head Department of Psychiatry at Women's Medical College, Ahmedabad. And he is a Vice President of Social Psychiatry Forum, for his valuable talk on stress management. And we will do on stress management. Professor, please kind come. Sir.
Bismillahirrahmanirrahim. Respected Professor Malik Saab, Rajam Saab, my colleague Professor Farid bin Haas Saab, Iftikhar Saab, Jameel Saab, जिन्होंने बड़ी बातें की भारत ऑर्डर के हवाले से. My topic for today is stress management. Stress, what is stress? What is the different types of stress, the nature of stress, the intensity of stress, the duration of stress. The history of stress is on this planet is when Adam alayhi salam, when he was thrown from the paradise, rather, and he came to this earth, the stress started. So this is not something new that I'm talking about. Next. This is the human reaction to events in our environment. Stress, अगर आप physics के हवाले से देखें, तो the force applied per unit area, and the force produces a change which is called strain, and this change or the strain is directly proportional to the amount of stress. So stress and strain formula. The strain or the change that is produced is directly proportional to the amount of stress. Next. There is a wear and tear on the body. तोड़ फोड़ का नाम है. जिस्म और ज़हन के अंदर, not only on the body, ज़हन और जिस्म दोनों के अंदर तोड़ फोड़. Next. This eustress is really very important, and this is a motivating force. This is a force for the improvement of the self and individual. This keeps you running. This is normal stress. This is not to be treated, because if this is not available, then most of the achievements in the society would not have been possible. For example, the stress before exam. एग्जाम से पहले जो स्ट्रेस है वो नॉर्मल है, उसको आप हटाते नहीं होते। इंटरव्यू से पहले स्ट्रेस, अभी इस पेपर के प्रेजेंटेशन से पहले जो स्ट्रेस थी कि पता नहीं ये जो नया गैजेट्स हैं और ये यूएसबी वगैरह काम करेंगे नहीं करेंगे, बिकॉज यू आर टोटली डिपेंडेंट ऑन दीज थिंग्स। So that is normal stress. Getting into college, getting engaged, engagement को normal stress कह सकते हैं, जब इन सब की अगर इजाजत हो। जी जी।
ब्लड प्रेशर ना हो तो कैसे?
नहीं, आपकी तीसरी शादी के वक्त मेरे ख्याल में ब्लड प्रेशर होता होगा। Getting engaged, winning the lottery, ये भी स्ट्रेस है, नॉर्मल स्ट्रेस है। नेक्स्ट, this stress from bad sources. डिफिकल्ट वर्क एनवायरनमेंट, अगर आपका माहौल ऐसा है और अगर आपकी सिचुएशन ऐसी है कि वहाँ पे काम करना मुश्किल है। मुझे इस बारे में एक शेर याद आया कि मैं तो इस शहर से हिजरत भी नहीं कर सकता, मैं तो इस शहर से हिजरत भी नहीं कर सकता, मेरे मौला मेरे मक्के को मदीना कर दे। तो मक्के में स्ट्रेस था, मदीने में दरामन था, तो शेर छोड़ भी नहीं सकता और शेर में रह भी नहीं सकता। डिफिकल्ट वर्क सिचुएशन, which is something very common nowadays. Overwhelming sights and sounds, जो बेताशा शोर आप सुनते हैं, और नॉइज पोल्यूशन। थ्रेट ऑफ पर्सनल इंजरी, दिस इज ऑल्सो डिस्ट्रेस। थ्रेट्स ऑफ इंजरीज, आप सही सलामत आदमी घर से बाहर निकलता है, वापस उसके लाश के भी टुकड़े नहीं मिलते। ये हमारा मुआशरा है, और ये हम इस तरह यूज्ड हो गए। पेशावर के खैबर बाजार में कुछ अर्सा पहले एक सिरे पे धमाका होता था, दूसरे सिरे पे दुकानें खुली होती थी और लोग कारोबार करते थे। They were used to it. इतना मुश्किलें इतनी पड़ी मुझ पर कि आसान हो गई। गम से खुगर हुआ इंसान, रंज से खुगर हुआ इंसान तो मिट जाता है रंज। मुश्किलें इतनी पड़ी मुझ पर कि आसान हो गई। थ्रेट ऑफ पर्सनल इंजरी। नेक्स्ट, जनरल स्ट्रेस. Everyone has this kind of stress. It is resolved itself within a day or two. Intervention is not necessarily required. No intervention is required. इसमें आपको किसी किस्म की कोई जरूरत नहीं होती, क्योंकि there is another concept, resilience, the concept of resilience, the bouncing back to the original state. किस हद तक हम वापस अपनी जगह पे आ सकते हैं। और कुरान के अंदर मेंशन है कि रसूल चीख उठे कि अल्लाह की मदद कब आएगी, मता नसरुल्लाह। अल्लाह के रसूल यहाँ तक स्ट्रेस में चले गए कि वो चीख उठे कि अल्लाह की मदद कब आएगी। तो अब वो रिजीलियंस की बात की जाती है। रिजीलियंस, पर्सनैलिटी ग्रोथ या इंटरनल ग्रोथ, या जो जिसको कहते हैं कि आप किस हद तक वापस अपनी ओरिजिनल पोजीशन में जा सकते हैं। तमाम गम और परेशानी और डिफिकल्टीज आ जाती है और सर्कमस्टांसेस, उसके बाद इंसान निकल के उभर के ठीक ठाक बन के वो सामने आ जाता है। और अंग्रेजी का एक मकूल है कि गॉड टेक्स यू टू द डीप वाटर नॉट टू ड्राउन यू बट टू क्लीन यू। मुश्किलों से गुजार के आपको कुंदन बनाया जाता है और आपको डबोना मकसद नहीं होता। नेक्स्ट, cumulative stress built up in your body, additive and accumulative. It becomes more difficult to alleviate your symptoms. You may have more serious physical symptoms, you may have more serious mental anguish. अब अगर यहाँ पे एक 10 बाल्टियां पानी के हाथ के अंदर फेंक दे तो उसका इतना नुकसान नहीं होगा। जैसे नल का होता है, उससे टिप टिप करके एक एक कतरा जो है वो नीचे जाता है। तो दैट इज द स्ट्रेस इज एडिटिव एंड accumulative. वो थोड़ा सा होगा, वो इतना ज्यादा पानी की मकदार भी नहीं होगी, लेकिन वो नीचे तब्दीली पैदा कर लेती है। यू मे हैव मोर सीरियस मेंटल एंग्विश। दोनों चीजें, फिजिकल स्ट्रेस रिलेटेड डिसऑर्डर्स, आजकल क्या है ना स्ट्रेस रिलेटेड हार्मोन्स, जिसमें आपके जो है वो मुख्तलिफ किस्म की कार्टिसोल वगैरह और वो टारगेट आर्गन की असरअंदाज होती हैं, और बहुत सारी बीमारियां ऐसी हैं जो कि स्ट्रेस रिलेटेड है। इसमें आपका कार्डियल इंफार्क्शन है, एंजाइना है, और टेंशन, हेडेक और मुख्तलिफ सारी ऐसी बहुत सारी चीज़ें जो इवन डायबिटीज़ के बारे में कहते हैं, हाइपरटेंशन के बारे में। नेक्स्ट, acute traumatic stress, critical incident stress produces considerable psychological distress, a normal reaction to abnormal events. आपका रिएक्शन नॉर्मल होगा स्ट्रेस के लिए, लेकिन इवेंट्स आर एबनॉर्मल, एक्यूट ट्रॉमा। नेक्स्ट, post traumatic stress, severe stress produced by severe psychological trauma. Trauma is not only psychological. Unresolved critical incident stress produces lasting changes. Trauma is physical, physiological, psychological. मुख्तलिफ trauma की शक्लें हैं. So we as a psychiatrist and students of psychiatry talk about the psychological trauma more. It is just like a blow. ये जो psychological trauma है ये भी एक थप्पड़ की तरह है या एक physical injury की तरह है. It takes time to heal. Next, ये जो आपका रद्द-ए-अमल है, how do you react to it? Stage 1 में alarm reaction, the fight or flight situation, response which causes you to be ready for physical activity. इसमें आपकी जो नॉरएड्रेनालिन है और एपिनेफ्रिन है, मुख्तलिफ हार्मोन्स हैं, स्ट्रेस सिम्पैथेटिक ओवर एक्टिविटी, वी कॉल इट सिम्पैथेटिक, आपका सिम्पैथेटिक नर्वस सिस्टम फ्लेयर अप हो जाता है, एंड यू आर रेडी टू फाइट और फ्लाइट, जिसको हम कहते हैं फाइट और फ्लाइट सिचुएशन, या आप मुकाबला करते हैं या आप उस जगह को छोड़ देते हैं। However, it decreases the effectiveness of the immune system, which makes you more susceptible to illnesses. ये भी बड़ी अहम बात है, इसकी बड़ी स्टडीज है कि stress reduces your immune system. आपकी जिस्म के अंदर जो इम्यूनिटी का एक सिस्टम है, स्ट्रेस की वजह से वो भी खराब हो जाता है। नेक्स्ट, Stage 2 of adaptation. If stress continues, the body adapts to the stresses it is being exposed to. ये अल्लाह की मेहरबानी होती है कि आपका जिस्म आहिस्ता आहिस्ता और जहन उसके लिए अडैप्टेशन शुरू कर लेता है। If the stress is starvation, the person experiences a reduced desire to physical activity to conserve energy, and the absorption of nutrients from any food intake is maximized. तो मुख्तलिफ स्ट्रेसेस के लिए एडाप्टेशन का जिस तरह मैंने कहा कि रेजिलियंस की मैंने बात की, तो रेजिलियंस डेवलप हो जाती है। नेक्स्ट, स्टेज ऑफ एग्जॉस्शन, ये वो सिचुएशन है कि जो पैथोलॉजिकल है और जिसमें आदमी थक हार के बैठ जाता है।
And you have last 3 minutes.
मैंने तो अभी शुरू किया।
अभी खत्म कर दें।
The body resistance may be reduced to collapse completely. The people who experience long-term stresses may have heart attacks, severe infections, or chronic pain or illness. Next. ये सिम्टम कोई नई चीज नहीं है मेरे ख्याल में, इसको मैं स्किप कर सकता हूँ कि एंग्जाइटी के सिम्टम और स्ट्रेस के सिम्टम तो बराबर होते हैं, इसको नेक्स्ट कर लें। ये भी लॉन्ग टर्म सिस्टम में इंसोम्निया, चेंज इन एपेटाइट, सेक्सुअल डिसऑर्डर्स, एक्स एंड पेन्स, फ्रीक्वेंट कोल्ड्स, फीलिंग ऑफ इंटेंस एंड लॉन्ग टर्म टायर्डनेस। बहुत सारे लोग शिकायत करते हैं कि बड़ी थकावट होती है, तो मुसलसल थकावट जो है ना, क्रॉनिक फटीग सिंड्रोम इज आल्सो वन ऑफ द रीजंस, वन ऑफ द साइंस ऑफ स्ट्रेस। नेक्स्ट, बिहेवियर में क्या हो जाता है। नेक्स्ट, स्ट्रेस का इंसानी रवैये पे क्या असरात हो सकते हैं। नेक्स्ट, these are all the symptoms which get negative effects on the human body by reducing your effectiveness, making your accident prone, causing you to be forgetful. यादाश्त, जवानी की उम्र में यादाश्त की कमी की सबसे बड़ी वजह स्ट्रेस होती है। Causing you to be very negative, you may neglect your appearance, you may make poor judgments, causing you to make more mistakes, increasing your absenteeism. Next. You may not take good decisions. Your fine motor psychomotor skills are affected. You may no longer enjoy your work. Your attention span may be affected. Distraction of attention. You may have more negative thoughts. Your self-confidence will suffer. You may have difficulty concentrating. All of your positive energy is consumed. इतनी जान नहीं रहती इंसान। ये थोड़ा सा healthy living के techniques, examine your diet, खुराक का ख्याल करो, lower your salt intake, lower your intake of refined sugars and carbohydrates, lower your caffeine intake. Next, add to your diet vegetable fruits. Next, रेस्ट बड़ा जरूरी है जो हम कंप्रोमाइज कर लेते हैं. मिनिमम ऑफ 6 hours ऑफ कंटिन्यूस रेस्ट. ये कंटिन्यूस नहीं होता, वो नींद टूटती रहती है और दोबारा होती है, सुबह उठते हैं आप फ्रेश नहीं होते. नेक्स्ट,
Thank you.
एक्सरसाइज. ये इस बयान की बात मैं करता हूँ. मलक साहब मुझे बिफोर ईयर इनकी तबीयत बहुत ज़्यादा स्ट्रेसफुल हो जाए मेरी वजह से यहाँ पे खड़े होके. तो एक्सरसाइज, जमान साहब हमारे टीचर थे बड़े सीनियर, वो कहते हैं अजीज मैं एक मजहब ईजाद करना चाहता हूँ जिसमें शुगर हराम हो और एक्सरसाइज फर्ज हो. थैंक यू वेरी मच.
सर आप ये थोड़ा मार के मैसेज.
Thank you, Professor Bhurban, for your valuable talk. Now I would like to invite Professor Fareed Minhas. He is Professor of Psychiatry, member of St. Dave Rawalpindi Medical University. He is pioneer and initiated Global Mental Health Program. Today he is going to talk about School Mental Health Project.
Professor Riaz Bhatti, Dr. Anju Bashir, Professor Mazhar Malik, what a pleasure it is to be in Bhurban on a Sunday morning in a conference which is very well organized and had a wonderful social evening last night. The topic that I sent Dr. Bhatti was about school mental health. And this has a combination to the presentation that Aisha made, that we think that majority of psychiatric disorders have their origins in the early childhood. And in the early childhood, the child is either at home or at school. And if those two things are missed, we are producing children who will continue to have psychiatric problems. And it is in this background that I put down my slides that why mental health in schools is important, what is the WHO's Global Health Framework, and what are the initiatives that we are carrying out in this country, and then lastly, some of the failures of my life have to be converted into some kind of success that I would like to talk to you in the Center for Global Mental Health. Now, these are some of the stunning facts that speakers from yesterday and today have been speaking to you, that 1 in 5 children will display signs of poor mental health at any given time that would meet a criteria of a mental illness, and about half of the mental illnesses will begin in childhood, and children's well-being is linked to their academic achievements, and the effort that the students put in is highly correlated with more positive academic outcomes. Now those are some of the things that you and I need to look into our children when we are parents or when we are teachers or when we are psychiatrists looking after the children. And I'm going to give you 11 facts. Not going to go into the details of that because that in the interest of time you wouldn't want me to lecture on this forum, but those are small bullet points, 11 bullet points that I think set the base for my worry about school mental health. Students spend a significant amount, around 15,000 hours from kindergarten to the completion, therefore be accessible to the mental health promotion, prevention and intervention in schools. The students' protective factors and resilience gets going at that age. The social development, which we think is so important for fighting the stresses and strains and the successes of life, takes place there. And we know that the programs which will focus on social, emotional, and academic learning, they would find the children to have improved attitudes, behavior, and academic performances. We know that working with children who have mental health problems is a big challenge, and that's where, when the teacher is pushed to teach 30 students, 2 students make noise, then that student of ours with a mental health problem gets absolutely into a difficult situation. We know that the student's emotional health is fairly important, and that is important not only for the school, for the students, but for the school teachers as well. And we also know that schools influence the adoption of both healthy and unhealthy behaviors. We know that if the schools and the school teachers are doing their job, there would be decrease in violence and juvenile crime. And lastly, on this slide, you will see that schools would play a significant role in the early identification of children with mental health problems. And you will also see that schools is a time where you would learn about deep and lasting relationships with the school staff, and these relationships also are protective and supportive. And lastly, children learn to express themselves and actively participate in the school activities at school and in the community projects. Now, these 11 points, if you look at any adult psychiatric patient and you go into their past history, those were the parameters, those were the pillars on which the personality of the child was made. Imagine our children going to school where teachers have no concept of what the child development is, what social adjustments are going to be, what self-efficacy is going to be, what self-growth is going to be, and how the questions that the child asks you has to be answered. Our teachers are not taught. Our teachers have no idea about what the mental health principles are. And that's where we thought that this was important. Now, over the years, I have realized that if you don't form a lobby, if you don't create a niche of collaboration with the world's renowned centers, Pakistan and Pakistani psychiatry will never rise. And this is just one example that I'm going to quote here, that this WHO has an Eastern Mediterranean partnership to implement the regional framework for mental health. And our country is signatory to the fact that we are going to deliver this regional framework in our country. And on the basis of this, my partners, Atif Rahman from Liverpool University, Lawrence Winslow from Johns Hopkins, and myself at the WHO Collaborating Center for Mental Health Research and Training at Rawalpindi, we formulated the school mental health program, which is a U19 research, and people here can tell you what U19 means. Probably one of the highest research awards that can be given by the National Institute of Health, and we are very lucky that we are one of the recipients. And in this program, we have the administrative core, we have the research core, and we have the capacity building, which is going to be delivered by our partners in Iran, Jordan, and Egypt. These are the people collaborating, and you will see the success of any activity is a partnership. If we work in isolation, we never rise beyond what we are. And in partnerships, we go because some of the partners are much more experienced than what we are. Now, what is our target audience in this program? That we are looking at those people who are educational, who are influencing the educational process, which would include the teachers, administrators, nurses, social workers, school counselors, in addition to the educational policy makers and the non-governmental organizations. And the objectives, you will see, are exactly in line with what 11 bullets that I introduced you very briefly. We want to help the educators understand the importance of mental health in school setting. We want to enhance the educators' understanding about the child development. We want to incorporate mental health into the school system's initiatives. We want to have age-appropriate behavioral and management strategies, including disciplining and management of disruptive behavior to these people. And we need to teach them how mental health can be promoted in the school settings. We need to teach them the warning signs of mental illnesses in school children and distinguish that from the emotional distress that many children at that point are going to have. And we need to provide them with appropriate interventions for a variety of psychiatric disorders that we see in schools. And we need to provide them with a resource that can be assessed by the educators themselves. This program has a timeline that we started from 2016, and we are going to end this project in 2021. I am not sure with the Jamil's classification of retirement whether I would be senile by 2021 to deliver this or not, but the program is going to last, and the program is built. Even if I drop dead, the program will go on. The teachers, what we have here is that there is a teacher's training manual that this program has brought out, and the workshops are being done for teaching those teachers at the Institute of Psychiatry. The program is being monitored and evaluated. And if you look at the phase 1, we are going to 72 schools. We are training 144 school teachers, and our job has to end by December 2018. And we have approximately 150 to 200 enrolled children in each school. And we have done this in Rawalpindi, one of the districts in Rawalpindi, which is Kalar Saina. The population is given there. And when we move to phase 2, we are going to go to the second phase in Gujar Khan, where we will have 137 schools, 274 teachers, and they are going to be trained by 2020, and we would have approximately 150 to 200 children which are going to be enrolled in this study. The innovations that we are making in this program is that WHO talks about task sharing and task shifting. In my lifetime as a psychiatrist, we started with 100 psychiatrists, and 30 years down the line, when I retired, we had about 400 psychiatrists. The equation continues to remain the same. The population is increasing. We are not going to have enough people to deliver all those goods. And therefore, WHO has come out with a task sharing and task shifting, which means that if I train people in the principles of mental health to school teachers or to nurses or to lay workers, they probably can deliver the same task that I deliver at the tertiary care center. And we are looking at the school teachers here, that we are going to give them the name of champion teachers who are going to be trained in the school mental health program, and they are going to be teaching the rest of the teachers in each schools. And these schools that I've mentioned, each of them, inshallah, would have 2 champion teachers here. We need to have the technological innovations, and we think that the training module that we have for this program, we are producing 5 videos, and those 5 videos are going to be uploaded, and teachers are going to go onto those sites, and they are going to download those videos, and they are going to be taught about the mental health principles. Days are gone when I would travel to Gujar Khan or to Kalar Saina to go and deliver workshops to the school teachers. Now with the smartphones, they are going to be sitting in their homes, they are going to be downloading these videos, and they are going to be completing the quiz, and they would get an online certificate of what they have learned in those videos. And we also think that we need to sell some of the models to the business community. The schools that I am going to are government schools. What is the ratio of government schools? People who don't get a job go to the schools. And how many children are there in schools? Absolutely dismal situation. I spent 2 hours talking to the school teachers who were newly inducted in Kalasaina. They were full of energy and vigor and knowledge, but they had no concept of what the mental health principles are or how they are going to be dealing with them. And it is our interest that we should involve social franchising, which would mean that boxing up the evidence-based integrated models and replication beyond the original science. And our hope is that some of the established institutions, systems in our school may be able to spend time and money and buy the product that we are selling. And remember, we are not selling it only for Pakistan, but we are selling and we are preparing it and selling it to the region that we belong to. For those who are very much in research mode early in the morning, this is the flow chart of the randomized controlled trial, and this describes that how we are going to take these teachers and the students and come to the end point in the full terms of assessment. The outputs, as I said, are going to be the training of the school mental online training, rapid replication, common outcome measures for the usage across the WHO region, business model for sustainability, and linking capacity building and research to develop trained human resources. Now that's a very interesting transition in my life. I handed over the reins of Institute of Psychiatry to Asad Tamizuddin. It's been a year now, and I thought at that point I was getting very wonderful offers from some of the private medical colleges that I should go and do that. And in the words of my teacher, Professor Mubashir, he described 3 stages of life. He said, first stage is you learn. Second stage is you earn. And the third stage is you return. And when I looked at the offers which were coming to me, I said, why do I need a job? I've done enough, and I have no regrets of doing another job. And by that time, Rawalpindi Medical College turned into the university. The Vice Chancellor called me and he said, these are the 5 posts that I offer you to apply and take. With humble knowledge, I regretted all those 5 posts. But what I did not regret is the fact that I'm part and parcel of that university. And I'm going to contribute to that university because I was once a student there. And the vision that we have at the Rawalpindi Medical University, where my input is coming in, is that this is a research-intense university. We are bringing in the indigenous models of research and education, whereby we are going to provide equitable, comprehensive, integrated, locally responsive, and sustainable evidence-based services. And we want to develop a public-private partnership with the academia, and there are many more people who are very well qualified, but they don't work in the government setting. And that's where the public-private partnership is going to come. And if any one of you is aspiring to be a politician in health, the last bullet is absolutely wonderful, that it is going to have the universal coverage in a Rawalpindi district, that the model that we are proposing. The way university is put down, don't go into the details, but below Vice Chancellor is the Board of Advanced Studies and Research, where I am the co-chair of this board, and whereby we thought that the vision of Rawalpindi Medical University would have a Center for Global Health and Development. Down below are the three centers: Center for Global Mental Health, which we have parked at my previous institution, Institute of Psychiatry. Then there is a Center of Excellence on Liver Diseases, and there is Center of Excellence on Child and Maternal Health. These are the three centers that we have initially gone in with, and we are more than happy for other centers to come in under the Center for Global Mental Health. The vision of my center is very clearly that we want to promote mental health equity, and we want to reduce the treatment gap for the mental health by training the next generation of health practitioners. And this is how the Center for Global Mental Health is going to be linked with the policymakers at the ministry in Islamabad, with research, with local research pioneers like Human Development Research Foundation, and the WHO and the education component is going to come at the Rawalpindi Medical University. And these are some of the thematic areas at the Center for Global Mental Health that we are promoting. I won't go into the details, but you will see, and Anjum should be pleased to hear that child and adolescent mental health is still our stronghold, and this has a direct relevance to the talk that I have given so far. Some failures that I said. I was at the helm of the affairs of the College of Physicians and Surgeons for a long period of time. We made all best possible efforts that we should have a second fellowship of child psychiatry, but for one reason or the other, we have failed to deliver that. But with the background that I am presenting to you, do you think we can afford to have psychiatrists in this country who have no practical training of child psychiatry, child development? And they are the ones who treat day in, day out all kinds of psychiatric disorders. So we have very good adult psychiatrists in this country, but their training in child psychiatry, for one reason or the other, has lacked. And since I failed in developing the second fellowship of the college, I said my energies should not go to waste, and here is some of the proposal. At the Center for the Global Mental Health, we are proposing that there should be a diploma for general and family physicians. We should be talking about leadership in mental health for general and family physicians. We should be talking about leadership in mental health. We should be talking about diploma in psychiatric and mental health nursing. We should be talking about diploma in clinical psychology, masters in clinical research, and diploma in child psychiatry. That's my wish list that we are seeing. And we are developing with the University of Liverpool and the NIH a model of 6 months accredited course that will be delivered online, and the monitoring of that would be done by the university, Rawalpindi Medical University. Ladies and gentlemen, thank you very much for your attention.
Thank you, Professor Reed-Naz, for your valuable talk. Now the house is open for questions. If anyone of you want to ask questions from the presenters, kindly come up.
Thank you, Dr. Aisha, for your assistance. We have come to the almost end of our first session. I have my colleague here, Dr. Anjum Bashir. He would like to give his comments on today's session.
Not all of the session I'm going to give comment on because you're getting ready for the tea. But I remember years ago in these conferences, I was the only lone presenter on issues of children. So this was like about a decade ago. And today it was so reassuring that I'm the only one who is not presenting a topic on child psychiatry. And there are so many others. So we've got Nazish leading from Lahore, Aisha from Rawalpindi and Islamabad, joined by Fareed. I don't know, Aisha, how you converted Fareed into all this. So Fareed was also converted into it, and Asad Khan from KP, and so on. So it's so reassuring that finally we are coming round and we are really giving attention to the children. And Fareed, the program we heard is fantastic. I think I was so reassured that how well it is built and integrated into school mental health. And Aisha's work on Ankahi, we had to wait for so long for Ankahi to start, but finally it has started. And I think similar initiative, Nazish, you are leading in Lahore as well, and so on. So I'm delighted about it. So I was very happy, so I wanted to say that.
I request Professor Riaz Bhatti.
Sir, you too.
Okay.
I
think this was the most enlightening session. We had people who have talked on a number of areas. We had first speaker, Kiran Mushtaq, talked about perception of maternal support and well-being of adolescents. Then of course we have got second speaker, Miss Mariam. She talked about stress and coping, family, single working and non-working women. And of course Dr. Nazish, she talked about the perception in patients of schizophrenia. I think all these papers, especially Professor Fareed Minhas, Dr. Aisha Minhas, and Professor Jamil, they are all talking about the social aspects of psychiatry, which have been neglected for a very, very long time. The initiative which I and Professor Riaz Bhatti took in organizing and bringing out the Pakistan Association of Social Psychiatry has all these areas, and we like that in future all our colleagues will be talking about areas like stigma, prejudice, discrimination of psychiatric patients. Child abuse is a very important area. We have been talking about it. Stress and stress management and school mental health program, and there are a lot of areas, domestic violence and areas of drug abuse, which have all social consequences. And I'm sure that in future we'll have more activities on this, and we'd like to welcome our colleagues to talk on these areas and do research. Thank you very much. And Professor will invite them for a certificate. There will be certificate distribution. Me, Professor Bhatti, for the speaker, and we'll come on the dais and we'll give the certificates to the speakers. Aisha,
would you call up name the speakers, please? One by one.
Now extra time for certificate distribution. For the first speaker is Ms. Kiran Mushtaq. I would like to invite her for our certificate. And the second speaker is Ms. Mariam Amjad.
Yes, please.
Thank you.
Thank you.
Sure. Thank you. Thank you.
Our third speaker is Mr. Howard Chaudhary.
He's an associate professor of general medicine at Continental Medical College.
The fourth speaker is Mr. Sajid
He's
Irfan.
half converted psychiatrist. Sajid from Karachi, mashallah, all the way from Karachi.
And I would like to invite Dr. Nazir Imran to collect her certificate.
Ready?
Thank you.
Thank you.
Thank you.
Professor Jamil Hussain Sahib, kindly come on stage to collect her certificate.
नहीं इधर इधर सर वो सर प्लीज
Sorry.
मेरी आखिरी अपॉर्चुनिटी है
Just a
I
bit.
would also like to invite
Look at the camera, yes, okay. Straight again, okay, yes. Ready?
Thank you, sir. ये अक्सर छेड़ देने इसलिए बस नहीं है
Professor
Sir,
Aisha
sir, sir.
Minhas.
Again, okay, just a bit.
जी सर
Ready?
Thank
Thank you.
you sir
Thank you, sir.
मैम आइए
Professor Fareed Minhas.
Just a bit, sir.
सर
Yeah, listen, yes.
मैम थोड़ा सा ना कैमरे पे ब्रेक
Ready? Yes, okay.
थैंक यू आइए सर ऑन सिंपल है अंजुम आओ यार अंजुम आओ आओ यार साइड वाला तस्वीर खिंचा लो सर
आ जाओ
Sir, just a bit.
The 3 old must be the yes.
सर सर सीरियसली
Yes, okay. Ready? Read कीजिएगा again, okay, yes. Thank you.
सर वो बात ही करनी और पी आयशा कोई और स्पीकर रह गए बेटे एनी स्पीकर
Announcement for. Thank you very much for all the speakers for their valuable talk, and thank you for all the audience for their patience.
Speakers के साथ एक group photo है.
The tea is ready.
Announcement करें speakers के साथ एक photo.
Okay.
प्लीज अगर स्पीकर से आ जाए एक छोटा सा ग्रुप फोटो
And all speakers should come
All
on
speakers,
front
please, sir.
for a photograph.
लेडीज में शिफ्ट ऊपर चले जाएं अगर ज्यादा विजिबल होना है
हाँ जी पीछे आ जाओ बिल्कुल पीछे आ जाओ
पीछे आ
ऊपर आ
जाए विजिबल हो जाए
Sorry.
विजिबल हो जाइए देखते
Ready? Yes, okay. Again, okay, yes. Ready? Just again. Again, okay, yes. Ready? Just please, sir.
थैंक यू आइए सर चाय